I think we have our next speaker is Dr. Vorovich, who will be speaking on tailoring MCS based on kinetics of shock. Role of echo.
Thank you. Thank you, Maron and company, for inviting me to speak and putting on yet another fantastic conference. So today I'm going to be talking about tailoring our MCS devices based on kinetics of shock, role of echo and hemodynamics. These are my disclosures. So first, I wasn't actually quite sure when I read the title what I'm supposed to talk about, so I texted a couple friends, and this was the results of what we all thought I should talk about, which is how to decide on a first-line device and quickly, how to decide on escalation, and I think echo hemodynamics are also important for de-escalation, but the talk is only 7 minutes, so I won't be able to talk about that, but I included a slide for reference if you guys are handing out slides. And basically, how do we do what we do on shock calls, and how do we use an echo and SWAN to help us? And so this is a great figure that's been shown before from the Utah group that really separates shock into these kind of 4 stages, or the acronym ROSE is recognize and rescue, optimization, stabilization, and then de-escalation. And when we talk about kind of how we're using SWANs and echoes in this, we're really focusing on the top portion where we're talking about how are we phenotyping, etiology, the pathophysiology. And by that I typically mean, is this a bi-V, is this an LV and RV or a bi-V problem? Acuity is not necessarily going to the echo and SWAN are not going to tell us acuity, but they can tell us some of those other things. But before we talk about that, I want to first focus on the bottom part, which is our targets. And what are our goals? Because I think those are important before we start talking about echo and SWAN and how we use them, because I think it's very important to always keep this in mind. So the first is to restore end organ perfusion and tissue perfusion. And blood pressure is part of this, but we're really talking also about regional perfusion. I think Nir's talking next about microcirculation. But blood pressure's, 4 pressors to maintain a MAP of 65 at the expense of like toes and kidneys isn't what we're going for, right? And if you notice, when this is our first goal, there's no SWAN number in here, there's no EF in here, right? So our first goal is a clinical goal. It's not a SWAN goal. And in fact, so I want to, as I'm talking about the use of SWANs and echoes, I might say like 4 different times that this really has to be put into the context of everything else. And I think Jason said that earlier today as well. We want to aim for myocardial recovery. This is really our holy grail, right? I'm a transplant doc, I'm our VAD director, and my goal is to VAD and transplant as few people as possible and to send as many people home with native heart function as we can, but with a quality of life, right? And then our goal is to pivot, if we can achieve myorecovery, to heart replacement therapies, whether that's a durable LVAD or transplant. So then how do we use echo and SWAN for the top part, which is the phenotyping? So this is also a nice figure from the paper that talks about how we phenotype shock and how we think about it. And there's a lot of different things that go into it, right? Part of it is the timing of, shock looks different minute 20 versus if you leave them in shock for 6 hours. There's sky staging, which we talked about a bit, hemodynamics, and then there's biomarker profiling. To kind of put it simply, when I think about phenotyping, I think about how quickly did we recognize it. The goal is always recognizing it ASAP. Is it acute MI shock or heart failure? Most of our data comes from acute MI shock. I'm completely biased in this, not on my disclosure slide. I'm a heart failure doc, right? So as the director of our shock team, I hear about the phone calls, from the cath lab. But what I see a lot when I'm rounding is my heart failure shock. How bad is it? And we have a lot of prognostic factors that are being studied, but are not quite ready in real time, I think, to make real-time decisions. I can't focus on all this stuff. It's a 7-minute talk. So, I'm going to go back to talking about SWAN and echo, particularly for this part of phenotyping, which is it RV, LV, or bi-V? And I want to put a plug in because SWANs are still underutilized, right? There is a randomized trial going on about use of SWANs in shock, but there is multiple registry data showing that SWAN use is associated with improved mortality. This is cardiogenic shock working group on the right. This is inpatient sample on the left, right? So we have an association. We use it and rely on it heavily, but again, in the context of everything else. The one plug I'll put in is, a lot of times when I'm getting patients from other hospitals, they don't have a SWAN. But don't forget to use what you do have, right? How many times we get called with a central line, but no one's checked the CVP, no one's checked the central SAT, and our residents now call it a baby SWAN, which I think is kind of cute. And how about like pulse pressure on your A-line, right? So there are some quote-unquote invasive hemodynamics that we can get without a SWAN that I think people forget about. So how do we choose support? So shock severity, right? This is our SCAI stages. 4-pressor shock is not going to be rescued by a balloon pump. Again, there's no SWAN number in that, right? Shock profile, is it univentricular or biventricular? There's a lot of practical considerations. If we can't transport someone, and we need, they're going to get cannulated on VA ECMO if we think they're a candidate for any temporary MCS. If oxygenation is an issue, we also pivot to VA ECMO. We often think about, can we get away with a balloon pump, right? All the wonderful data that the 2 prior presenters talked about was in acute MI shock, and it doesn't really apply to heart failure shock. And in fact, I think someone mentioned the data from Columbia, which is a wonderful paper that shows that my patients tend to respond to balloon pumps much better than the chronic heart failure patients tend to respond better to balloon pumps. As we're evaluating patients, we're immediately thinking about contraindications to Impella. They do provide more support than balloon pumps. So we're thinking about all this kind of simultaneously. This is where an echo can really help. We're thinking about access and anticoagulation issues. We're thinking about timing and resources. You have to know what you can activate, what devices you have, what people you have, and what their comfort level is with different things. I'm very lucky. I always say I'm kind of like the general contractor. I never get my hands dirty. I'm not a plumber. I'm not an electrician. I don't do the drywall. I just do a lot of talking, which my surgeon reminds me to do a little less of sometimes. But you have to know I'm lucky that I have everyone available who can do anything. But that's not true at every institution. We are always thinking about our end goal, as I mentioned before, and planning ahead. So a common thing that we have to do if we're activating in the middle of the lab, we put in the middle of the night, we put in a Impella CP, but we'll put in 5 French sheets that if someone does worse and we need to crash them onto ECMO, we can do that in a less chaotic way. And then actually sometimes we'll then change the ECPella if we think it's going to be a while or we think they're going to need to bridge them to transplant to a 5-5. And it's kind of a very kind of nice landing strategy for them. We have an algorithm here at Northwestern, different centers. I looked up Inova's to remind myself. They have subtle differences, but at the end of the day, everything is trying to focus on the right device for the right patient. And not under-supporting them and not over-supporting them and figuring out RV versus LV. And this is where SWANs are very helpful. So at the bottom, we use wedge and CVP, and then we use PAPI. People use different things. I don't think it matters whether you use CVP of 14 or 15, and these are guidelines. And I think there's a couple themes I've heard through all of the talks, right? One of the themes was, it's complicated. One of the themes is never use always or never. Don't be dogmatic, right? At the end of the day, every patient is different, and guidelines aren't a Bible, even if it's your own protocol guidelines, right? So we use this just to kind of guide our thinking, but we really are individualized. How about assessing adequacy of support? So one is, you have to assess very frequently, but what we assess, how is our blood pressure? Am I coming down on inotropes and pressors? Are my end organs happy? Is the lactate coming down? Notice there's 0 SWAN numbers in any of this, right? And there's no echo in any of this either, right? So these are clinical decisions. From a SWAN perspective, our goal is to have an index more than 2.2 because that effectively delivers this is also a paper I think from Utah as well, like in the review paper about like an oxygen delivery that is the kind of the goal that we're looking for. We want adequate filling pressures, we want myocardial recovery, and we can't measure myocardial oxygen demand, but we want to be thinking about it, right? Because we are aiming for myocardial recovery. I'm finishing up. But so at the end of the day, my summary slides is it's complicated, so don't be dogmatic, and this is why we have shock teams, right? Is to have multidisciplinary input.
Thank you very much. It's a great talk.
Thank you, Esther. That was really well done. I have a question in relation to what you said about the SWANs and what Nir said earlier about the guidelines. And when we put things in the guidelines, we need always to remember that people will extrapolate. And we all know what happened after the ESCAPE trial, which was for a specific patient population, and then things got extrapolated, and 3 out of our speakers today talked about the damage and our trainees after a point stop using or being trained at this, right? So going back to what you showed here, what do you think about the swans now, and how do you implement these in your day-to-day practice?
So we are heavy SWAN users. I think we would have a hard time randomizing in the trial. Do we have them on 100% of people? No, right? Obviously, first of all, we have an eCPR program, so those folks don't always have SWANs. I'm a big believer that if I'm going to be providing particularly the level of support of Impella or higher, I want a SWAN. I want to know what my RV is doing versus my LV. As a heart failure doc, I'm already thinking to the next step, like, am I going to need to VAD or transplant this patient, right? And the RV is going to play a role in that. So I don't think we can separate that without the SWAN. Do I need it 100% of the time? No, right? So a lot of times we have we've talked about different scenarios today where we can't get one or whatnot, but if I have a CVP and I have a CVO2, and the CVP is 20, we're on 3 pressors, and the CVO2 is 40, I'm not going to say, you know what, I'm not sure what's going on. I don't know if this is cardiogenic shock. Let's get a SWAN, right? If my echo shows an EF of 10% at that point, I don't think this is isolated RV failure, right? So I think it really has to be taken into the context. We happen to be a SWAN-heavy place. I do enjoy, we will often ask for them, but I think, the last speaker who said never and always, which are also good, relationship advice, right? You never say never, you never say always, right? Being dogmatic is not a good way to practice medicine. And so it's a long-winded answer, my surgeon would say, to your question.
Esther, as a heart failure cardiologist, I think we all talk about balloon pumps and how they work in chronic heart failure. In a comment and a question, I think a part of physiology of balloon pump that I feel is understudied is the Winckel effect of the aorta and the stiffness of the vasculature that goes through remodeling in a heart failure patient. We think about myocardial remodeling and then get fixated on the 0.5 output. But I think, at least in my experience, these patients who have vascular remodeling in chronic heart failure seem to respond better with balloon pump. Mm-hmm. My question to you is, in my experience, like while we're talking about Impella and ECMO and activation, I just throw in a balloon pump at bedside, and randomly there are some patients who are on like 5 pressors who I never thought will get better, just get better like this. What is the role for CPO, cardiac power output, as a counterpulsation device? I think Manreath had a paper showing there's a signal. And are there any echo or hemodynamic measurements that we could use to predict response to balloon pump so that we're not putting it in people just as Hail Mary and escalating unnecessarily, or relying on it? So
the Columbia paper is great, but it's also like 132 patients, I think, right? And so it's hard to find markers, but they, ischemics did, they had a lot of double negatives. So ischemics and RV failure had a higher likelihood to progress to needing escalation, right? But at the end of the day, I've also had that experience, right? And so I have had 3 pressor shock, not even in chronic heart failure. It was an immune checkpoint inhibitor who had a little vasodilatation, which we heard before, we never use a balloon pump in, who did phenomenally well with a balloon pump, right? And I don't think we have markers. To me, the marker is a chronic heart failure patient automatically puts me into the category of, I think there's a good chance that they'll respond to a balloon pump. If I started throwing in, one, I haven't put in a balloon pump since my fellowship, so I won't be doing them at the bedside. But 2, like, we don't, hair would stick up if we started doing balloons at the bedside. That's not a thing that's done at our institution, so that's not an option. But there's also a lot of smaller patients who, by the time we hear about them, are on 2 pressors, where sometimes we get into the cath lab and we put in a balloon pump because their vessels are too small for something else, and then we reassess. That's where we put the 5 French sheath in. And we see, like, if we can come down on pressors, can their vessels be a little bit bigger? I don't use CPO in heart failure. My patient's outpatient CPO is probably low if I was to measure it, right? Like the one who walk into my office. I think that is an acute MI measure more than a heart failure measure, my personal bias.
So, Esther, first of all, great talk. The challenge is sometimes we're talking only about to choose the right device, but actually you put in your slide, the slide from Utah that show the first thing is the timely recognition. The majority of the challenges is actually that we pose ourselves to put a much heavier gun because we don't recognize the shock at time. And I think that's where the baby swan that you mentioned, I like the name, I was not familiar with it. But the importance of SWAN, or for us, or hemodynamic assessment, something objective, is to take other parameters, because the traditional parameter, the physical exam, the lactate, they don't tell the whole story. So I really interested to see what is, are you now pushing your people just put even CVP, take a CVO2, or that's what you're pushing at the
Even
moment?
on the shock call, because and a lot of times we'll also get calls, right, non-cardiac shock, right? So we'll have the SICU will call us routinely, and it's always like an intern who's somewhat scared to both call us and scared of their attending, and it's a surgical intern, and like no one's checked the CVP, and I'm like, there could be 3 different types of shock going on, right? Like, why don't we start with a CVP and a CVO2, and then a fellow will walk over, like we'll send a cardiology fellow to help sort it out. But absolutely, I think the enemy of good is perfect. Like, a SWAN is fantastic, it's great, but you can't be paralyzed by not having one. And I think this is where the whole doctoring thing comes in, right? Like, I've also walked into rooms and I'm like, this person looks terrible, something terrible is happening. We don't have a SWAN, we don't have anything, and I'm like, they're in shock, right? You can do that, right? Like, but not everyone I don't know, I only know like 3 antibiotics, right? The big guns. I can't treat community-acquired pneumonia in a healthy person. I don't know that. So I don't expect a non-cardiologist to necessarily have that same response. And so it's helpful when we can have all the data, but we need to be able to still be clinicians. And then I think we have to problem solve, right? Like, just like we teach our kids to problem solve, use what you got.
Excellent. Well, thank you. We need to cut it for the next talk, sorry. Thank you.